What do you recommend that somebody starts to do if they are hearing some of this and they're like, okay, so I have inflammation and I don't feel like myself, and maybe I'm starting to enter into this perimenopause phase, but I don't know who to go to.
Right.
Or what to do. Where do we start?
So I wish I could tell you could just confidently march into your wonderful OB-GYN's office who delivered your babies and has done magnificent care, because I was her.
Yeah.
Okay. We weren't taught, we weren't trained. If she or he has chosen to step outside of their usual training and get Menopause Society certified, or, I was self-taught initially, that's great, but they're hard to find. So Menopause Society has a list of certified clinicians on their website. It's not perfect, but that is a place to start.
It's a good start.
We have compiled a list of testimonials from my beautiful followers. We have several hundred clinicians who they felt wonderful with, and they've written these beautiful
on your
testimonials
website?
On my website, and we have divided them by city and state and country. Even we have some in Canada, some in Europe. So that's another place. There's some great telemedicine options now. Mm-hmm. I think that is a wonderful way to fill this gap, where they're specifically trained to do menopause care. And there's 3 that I've kind of not vetted, but talked to their owners, looked at the protocols, think they're doing a great job. MIDI, Alloy, Evernow are wonderful, options. There's some not great ones out there. So if I don't mention them, they may be good, maybe bad. Just do your research. Talk to your friends. Do they have someone in your community who's doing it? It doesn't have to be an OB-GYN. It could be family medicine, internal medicine, really anyone. It doesn't have to be an MD. There's some incredible nurse practitioners and PAs out there who are doing wonderful menopause care.
It's really about somebody who is passionate about it, will listen to you and personalize treatment, right? And who's staying up to date on latest research.
Yes. And hard to do. When your medical organizations haven't changed ACOG is not, American College of OB-GYN has not changed the menopause guidelines in 14 years.
Well, I have a lot to think about ACOG. I mean, when it comes to fertility, they say that there's no reason to even screen for, your egg count in somebody who's not actively having infertility, because it's not going to provide helpful information, and it might stress you out.
So we just now there was a big meeting in Europe, and we have a group chat we call the Menopause.
I love it.
And so they're worldwide. And so we have a lot of clinicians in Europe and Asia and different places. And so we're always like, what's going on in your country? So there's this big Andropause and Menopause Society meeting in Europe. So they were saying, Martha Hickey from Australia, who kind of runs their Menopause Society there, got up and said, we are scaring women. Talking about the suicide rates during perimenopause is scaring women, and we should not be doing that.
So we should stop talking about it.
Right, because we're putting ideas in their head. I'm like, excuse me? When did we infantilize our patients?
Oh, my God.
Like, this is who is, like, this is the old school, old guard.
But that's who's in charge of societies. I mean, like ASRM, Menopause Society, ACOG. I mean, we see that there's an old guard who feels like patients can't see data and hear risk benefit or make a decision.
Right. And they don't trust women to make good decisions for themselves. And I think that's a mistake.
I think so too. Good segue into HRT. So why don't we explain a little bit about HRT and your approach to it to somebody who might be thinking, can hormone replacement help me?
So there's many words, many titles, hormone replacement therapy, hormone therapy, menopause hormone therapy. So hormone therapy is just giving you hormones. That could be thyroid hormone. That could be,
I love that take. Because we give hormones all the time. People don't think twice about taking thyroid hormone.
That's hormone therapy. Anytime you put a hormone in your body that you didn't make naturally, that is hormone therapy for whatever reason you need to use it. Okay. Specifically for menopause, we have MHT, which is menopause hormone therapy. And for the new menopause, that is the term I kind of use to differentiate. Birth control pills are hormone therapy.
Right.
So for menopause hormone therapy, we have 3 buckets of hormones that are, our sex hormones. So we have estrogens, we have androgens like testosterone, and we have progestogens, okay? So specifically amongst the people that I've learned the most from, trust the most, the number one product we're trying to give a woman back is what her ovaries used to make, which is estradiol.
Right. Replacement in a way, right?
And so we are replacing what she used to make, or we are supporting what she's struggling to make. So in perimenopause. And usually we're trying to use estradiol to do that. Now, in a birth control pill, we use something called ethinyl estradiol, which is not estradiol.
It is not. Doesn't even show up on an estradiol blood test.
No. So like if I have a patient who comes in on birth control pills for whatever reason, she needs it for contraception, and I happen to accidentally draw an estradiol, it is 0.
Hold on. I will get
It is
sent patients
0.
all the time because they will have hormones drawn on birth control pills by their OBGYN who's trying to help them, and they have an FSH, LH, and an estradiol drawn while they're on the pill, and they're all between 0 to 1, and they get sent to me with this like hypoestrogenic, hypothalamic amenorrhea whole thing. I'm like, you're just on the birth control
You're on birth control pills. And so ethinyl estradiol is 300 times more bioactive than estradiol. It does bind to the similar receptors, but it doesn't exactly do the same thing. And so in perimenopause, I have options to either use a birth control pill, like if she needs contraception or having heavy bleeding, if there are symptoms that I'm trying to manage and control, sometimes birth control
the pill is the best
would be a good option for her. Or, if she's not having irregular bleeding, if her husband's had a vasectomy, she's got an IUD, I may go straight to estradiol. So options there. In the progestogen world, we have progesterone, which is what our ovaries make, and then we have about 9,000 synthetic progestins, okay?
And they all make you feel very different.
Right. And they work very differently. I love having options. Progesterone's not the best thing for everyone. Some people don't tolerate it very well, but it is my go-to. So you asked for my go-to. Estradiol, oral micronized progesterone. And then for androgens, I'm doing straight up testosterone.
As the testosterone that a man would be prescribed.
Exactly. I actually borrow my husband's,
do a little
I
squirt.
say a joke. He actually has plenty of testosterone. His levels are fine. But I borrow the men's version to treat my female patients. We just have to do a microdose because it's so concentrated. They don't make one for women. So my option is compound it. My patients travel quite far to see me, and I don't know every compounding pharmacy in Texas. Right. So I'm going to go with the FDA approved
option. It's FDA approved, right? We know that it's safe on certain levels. Even if it's not FDA approved for women, it's been through some validation.
Right.
And that's always better than maybe not knowing exactly.
But my go-to is not compounding. Right. I like having it as an option. Not everyone fits in the box. But, I just want your listeners, anyone watching to understand, you do not have to have compounding to have a safe, efficacious, and bioidentical hormone therapy. All of that can be provided from CVS.
I think that's a really important point because sometimes we go down the rabbit hole and we think that if it's not this one thing that this one person is on or said, that it's not good. And what I'm hearing from you is that really this is something that should be personalized.
Exactly. Individualized.
Not a one size fits all.
Right.
It really depends on the stage of life you're in, your goals, because estrogen replacement alone is not contraception. And we know this because young women who go into premature ovarian failure, when we put them on estrogen, and we usually cycle them with some progesterone, they will start to ovulate again. It'll be very sporadic and very random, but that estrogen will lower their FSH. And if they have just a few eggs hanging out, they can have a random ovulation. And I've had patients get pregnant after years on estrogen therapy if they went into ovarian failure in their 20s.
Yeah.
So I say, hey, this doesn't mean for sure that this is a contraceptive option, especially if we're talking about this perimenopause time frame where we know that women still do have eggs. And even if pregnancy is less likely, it's not a zero thing. And we should have good, reliable contraception if that's the option.
If she needs it, yeah.
If she needs it. What do you think about non-hormonal strategies? So obviously, I think that sometimes maybe
you
hormones
have patients
aren't right.
who have contraindications. They have a tumor being fed. They, they're in the middle of a workup for a stroke. They're in the middle of a workup for a DVT. They're not a great candidate. They have undiagnosed vaginal bleeding. And what do you do? Right. Unfortunately for those patients, estrogen is wonderful because it binds to all these receptors all over the body. Right. I can decrease her risk of cardiovascular disease. I can decrease her risk of colon cancer. I can decrease her risk of osteoporosis by 50%. Nothing else does that all in one efficient way. So I have to treat her hot flashes separately. I have to treat her, musculoskeletal pain separately. I have to decrease her risk of cardiovascular disease with lifestyle options, with statins, whatever we need to do. And so, it's a very piecemeal version if she's not a candidate, but there's no supplement that is going to grow your eggs back. There's nothing
we would give it to
works
you.
Better than estradiol. Trust me, I would have it on the market right now. Yeah. So, but that is the best thing. But there are patients who don't want it, totally fine, or aren't good candidates. And so we have to really piecemeal their care from there.
I see this sometimes where somebody comes into me and they say, I just don't believe in that, or I don't want that, before they've heard about it. And often we're talking about IVF, or maybe we're talking about hormone replacement. Well, I know my period's not here, but I do not want to be on estrogen, or I do not want to be on the birth control pill. And I always say, you get to choose what's right for you. But my plea is that you make the choice after you've learned.
Based on facts and not
Right?
fear.
So instead of just saying, I heard this, or I read this, or somebody told me this, we learn about the options. And maybe what you're saying is absolutely the same conviction you'll have afterward. But very often, once women really step back, if they hear and they're presented choices, they'll actually make a choice they thought they never would, because that was based in fear.
And misinformation, misguidance, someone trying to drive you towards one option, and not give you the menu of options and let you make a decision for yourself. I have a huge problem with that.